Hey everybody, welcome back. I'm so excited today because we have Dr. Maria Sophocles on again. You were on like a long time ago.
One of the very first.
One of the very first. I don't even know how that happened. We're like 4 years in and you're back because you did an exciting thing. So thank you for coming back to talk about it.
I'm excited to be here.
You did a TED Talk on the last TED Women's conference that they had, October 2023, right?
Exactly. The last talk of the conference.
Last talk of the conference. So the talk was titled What Happens to Sex in Midlife? Tell me, because I've done this before, so I know how it works, but tell me, was that how the talk started? Was that always the idea? Or tell me the evolution of the idea until it got to the TED stage.
Yeah. So I had, well, the short answer is I had written a book about sex in midlife, and then COVID hit, pre-COVID, and I didn't really do anything with it. I just threw it on a shelf. And then I got COVID in December of 2022. And I've had a week to sit around thinking about, should I do something with this book? And I said, yeah, I think I'll try to get it published. And then I said, maybe I could also talk about it. And so I submitted an application to TED. And I had submitted this application about 4 years before, and it came down to me and one other person. And they gave the slot to the other person, and she talked about periods and diarrhea, and it was fine. But I thought it wasn't as important as my topic. So I was salty for a few years, like, oh well. And then I thought, no, if it made it to like really close to being accepted, let me try again. So I threw it back in the mix, and the guy emailed me within an hour and said, where have you been? I've been waiting for you to send this back to me. I love this topic. It has to be on the TED stage. And I thought, oh, great, I guess I'm in. But it doesn't mean you're in. They have to go to their committee and convince the other curators that this topic and this lens and this person are the right person. So that was in Christmas time, and it was really June before they called me, very beginning of June, and they said, yep, we want you to do it. We have only one request. And I was like, what's that? And I was praying it wasn't like delve into data and science and math, because those aren't really my things. My thing is humor. And I was like, what are they going to ask? And they said, just bring humor to it. Just let it rip and let it be humorous, because it's a topic that can be intimate, difficult, sad. And we need you to find a way to make it serious but humorous. That's long-winded answer.
Awesome. I think where we are with education and midlife and menopause is, we could just spend the rest of our lives saying menopause is not just a hot flash, right? And where people are with that education, it's shocking, that they don't think the changes for women, for vulva owners, has to do with changes of hormones. So talk to us briefly about how the vulva and the vagina change in midlife and how that can affect your sex life.
Right. So agree with you 100%. Most people know that menopause is going to mean hot flashes. And after that, they get kind of murky about a lot of the brain things, the joint aches, the, hair and skin changes. But they really are in the dark about genitourinary changes, which you and I have talked about ad nauseum on air and to our patients. And they still aren't aware that when the ovary makes less estrogen and less testosterone and less progesterone, especially estrogen and testosterone, these have massive changes on the bladder, the vagina, the urethra, the vulva. And when there's less estrogen, there's simply a lower quality of collagen that is made. And that affects the elasticity and youthfulness of all that tissue. And we need elasticity for comfortable sex. So it's not a shocker that if we make less collagen and it's shoddier quality collagen, that just riding a horse or riding a bike or sitting around can be uncomfortable on the vulva. And having sex, the vagina is one tough organ. I mean, we go through periods, we go through childbirth, we have penetration by penises and vibrators, and, it's over the millennia become incredibly resilient. But when you make the collagen different quality. It's actually a different type and a different structure that's going to affect your ability to have comfortable sex. Ditto for blood vessels. Less estrogen means fewer blood vessels are made. And you and I can see this when we examine a patient. The vagina of a 25-year-old is different color and elasticity and moisture than that of a 45 or 65 or 85-year-old. And unlike hot flashes, which can come and go, and I hope they come and go quickly for people, yes, they can last for several years, but ultimately, most menopausal changes sort themselves out. Even brain effects, even the brain fog will resolve after a while. But bladder and vaginal changes are chronic and progressive. And this is bad news. This means that if it feels a little dry and uncomfortable at 57, it's not going to feel better at 67 or 77. It's going to feel worse. And this is why clinicians like you and I are so urgently adamant about helping women, as early as possible, get ahead of that curve and stay ahead of it by reversing these changes, which we know we can do safely with vaginal estrogen and other things too.
Yep. Where are you with vaginal estrogen being a preventative medicine?
I mean, they say for the statins, put it in water, right? I feel like I would remember in COVID, everyone got a check. I'd like everyone at 47 to be sent by the government a prescription, not a prescription, like 4 tubes of vaginal estrogen. And then I'd love that to be just part of your Social Security benefits or something.
Yeah.
I just feel like it's really hard to find women that this will not benefit. Now, certainly if you have active estrogen receptor positive cancer, I think you're not going to want to take it. Your oncologist isn't going to want you to take it. What's your feeling, Kelly? Like, would you even give it to someone with that? Or
Oh yeah, definitely. I think the data is,
but that's a hard sell, right?
yeah. Well, but things, you can sell things easier when people are educated. So they just need education. Fear is not facts, and we can work with fear by giving people facts.
That's true. So there's almost no woman.
There's almost no woman. Now, there is a little data that says, hey, if you're on an aromatase inhibitor, there might be a negligible, probably negligible, but slightly higher increase in basically bringing in that estrogen into your body. Whether that's clinically significant or not, we don't know. One retrospective Danish study was interesting. I'm going off on a massive tangent, but people need this education. Retrospective Danish study saying, hey, women who had breast cancer who were on aromatase inhibitors and took vaginal estrogen had a slightly higher rate of recurrence, but not mortality. But the women who were on systemic hormones after breast cancer did not have a higher recurrence or mortality. Now, science and data. How is that even possible? It just tells you, this data wasn't clean.
You need more data.
Yeah. So some people will take that paper to say you shouldn't be on vaginal estrogen with aromatase inhibitors. And I argue, but the systemic people didn't have a higher recurrence. I think it's messy data.
And I think the aromatase inhibitor is going to suck up any estrogen it can detect in your bloodstream. Yeah. And what about intrarosa? Would you put those women on intrarosa? Right?
Love it. And there's data.
Yeah, exactly.
Yeah. But, so to me, if you're currently being treated for breast cancer, just get your buy-in of your oncologist, an oncologist who knows. Right. I recently put a metastatic breast cancer patient who had been sold a bill of goods on lasers and magical potions for the tune of thousands of dollars. I simply picked up the phone, called the oncologist, and said, what's the reason that I can't give her vaginal estrogen? And he's like, give her vaginal estrogen. And then I got pissed because I'm like, you're telling me a $20 solution? This woman spent thousands of dollars on lasers and potions.
So they don't preemptively tell the patients. That's my fantasy, is that you and I could get a video to every oncologist in the country that treats breast cancer survivors and says, look, first of all, the hormone negative cancers, could you please not worry? Because there's no way this can do anything. Exactly. And see if they can at least preemptively give them peace of mind so they can come in our office saying my oncologist is okay with it. That would be fancy world.
You cannot be a urologist who treats prostate cancer without telling a man up front that erectile dysfunction is a consequence of this treatment and what we're going to do about it if it happens.
But too many of our
patients are standard of care in prostate cancer.
Yeah, but they don't get the same. They walk into
Women,
my
breast
office
cancer,
and
yeah.
say, my oncologist said I'm so lucky to be alive and la la la, and aromatase inhibitor will keep me alive, but told me nothing about the genital effects of it. Nothing.
Yeah. Well,
So,
I learned from an oncology nurse the rate of divorce after breast cancer.
oh, that's sad. Oh my gosh, that's
Yeah,
terrible.
it's
That's
terrible. So
well,
we're letting people suffer, and we're
good.
traumatizing relationships, and
Yeah.
we're not giving anybody help. The other thing that I thought was awesome in your talk is you, because you're well trained, you can, because I say this to my patients all the time. I'm like, I can tell you what your hormones are, roughly. I can't give you a lab value, but I can tell you by looking at your vulva.
Yeah.
Right? Like if you're very well trained, you can tell that there's been no hormones for a while.
Totally.
And but I don't think a lot of clinicians are well trained. And you can have symptoms and still have a vulva look normal. So the water is muddied a little bit. How many women do you see? And they're like, they told me I don't have atrophy, so they didn't give me vaginal estrogen. I'm like, if you have
Right.
dryness, if you have pain, if you have recurrent UTIs, there's no reason not to start you on vaginal estrogen.
Right. It's a zero risk, all positive, all upside thing. And it's the same, so many patients just say the word, I didn't feel listened to. And I think, good clinician knows that number one, they have to be able to tell you care. That's actually the beginning, right? And once they tell you care, you have to give them permission to talk, give them space. And number three is listen. If they're in pain, they're not drug seeking. They're not looking for opioids. They want to feel better when they have sex, or they want to stop having recurrent UTIs. And we know that vaginal estrogen will do that for them. So just because it looks kind of pink to you, I don't think you should override their complaints.
Yes.
And then the flip side is easy. If you put a speculum in and the vagina is bone dry and the pH is super high and it's yellowish white and pale, pale pink, and there's no rugae, I mean, that's like, vaginal atrophy 101, right?
Yeah.
We all call it GSM now, but plenty of clinicians still just call it vaginal atrophy. I hate both the terms. So, they both make us sound like we're one foot in the casket.
In the 80s, it was the senile vagina.
Senile, okay, so even worse.
So even worse.
I didn't think we had worse, but we did.
Yeah,
Okay.
we did. 1980s.
Yeah.
So tell us what the bedroom gap is.
The bedroom gap is a term that I coined just to explain or try to have a term for the difference in sexual expectations and, in some cases, abilities between men and women. It also is something, that gay couples experience, especially couples of different ages. So it can be heterosexual or homosexual. It can affect abled, disabled. It can affect, pretty much any socioeconomic group, any religious group, any geographic location. It's universal and ubiquitous. And it's based on the physiologic changes that we just spoke about, the collagen and blood vessel lack that leads to changes that make sex uncomfortable for women. Now, men age too. We know, I'm not going to tell a urologist about, the male reproductive system aging, and they experience erectile dysfunction. But for 25 years, we have had reliable and available meds for erectile dysfunction. I'm not saying they're perfect. Sometimes they're very expensive. Sometimes people can have side effects. But overall, the ED meds have been a global phenomenon that have helped, can we say millions? Probably millions of men
God,
around.
can we say billions yet?
Okay, billions.
Like,
I went on something they cut from my talk for time, but
Mhm.
I went on a vacation to a little tiny island in Mexico. Like I tried to find the place that's the most opposite of, Cancun as possible. Like nothing but jungle and one little pharmacy and a bicycle. That's where I went for a vacation. And I was walking around the town, which was like a restaurant and a pharmacy. That was it. I go in the pharmacy just for kicks. They have like a diabetes med and a blood pressure med and tons of Viagra, like cases and cases of it, and nothing else. Like they don't have anything. I think one antibiotic. So it is so ubiquitous, and I'm happy. I'm happy that men have that. Men didn't cause this bedroom gap, this difference in ability and expectations, but having Viagra just widens the gap, because if you're 62 and have a way to have an erection over and over again on demand, and your wife is literally bleeding or in pain, and someday I'm going to make a mural of all the terms that I have heard over 30 years. Razor blades, cactus, feels like the desert. I mean, one woman told me, I need Invisalign for my vagina. It's more out of whack than my teenager's teeth. It's misery. And honestly, Kelly, I feel like it's an uneven playing field. So it's a call to action. The talk is a call to action for our medical community to get educated, right? 4 out of 5 OBGYNs are not educated on menopause. Probably more than that are not educated on sex. Sexual health has not really considered like a medical thing, right? Don't you find that? It's like this awkward, we're a weird country.
It's extra. I mean, even insurances, right? Because I think a lot of women in their anger and desperation, they're like, but insurance covers Viagra. And I'm like, well, technically, no. A lot of insurance doesn't cover Viagra. A lot of insurances just say we don't cover anything sexual health related, which is kind of bizarre. Like, who made that up? What Puritan wrote that 20 years ago and it stuck around, right?
And then I think doctors bring that into their exam room. If you're a little squeamish talking about sex and you're not you, and you only had one lecture in med school and you're time pressed, you're going to focus on their thyroid and blood pressure, or if you're an OBGYN or urologist, you're going to focus on other stuff and maybe hope to gosh they don't bring it up and you can get out without having to talk about it. Like the little kind of researchy stuff I've done has looked at that, and how physicians themselves many have their own puritanical squeamishness from their upbringing or their church or their mother or their own awkwardness about their body. There's so many factors that come into whether a clinician or a provider just even brings it up. Yep. And if they don't bring it up, so many women are loath to initiate. They feel embarrassed or awkward.
100%. Like, women are shamed for ever talking about sex, let alone like to a professional who might judge them, right? It is a big barrier. Yeah, for to be like, oh, just go talk to your doctor about sex. It's like, you try that, man. That is, they're gonna fail.
Yeah, I think the one little ray of sunshine good news is that with the advent of online dating, this has been a mixed bag, by the way. It's also been a mess for people because suddenly they're thrust into, I can have 3 dates in a week and 3 men ask me to have sex, and oh my gosh, all I've ever done is had sex with my ex-husband for 30 years, so it's a little overwhelming and scary. But the other thing is, it's brought women into my office saying, I'm divorced or I'm widowed or I'm single and I'm menopausal and I'm having more sex than I ever had and I need help. I can't just put my husband off anymore. And I want to be vibrant. I want to be in the game. So
I love those visits.
Side is like, they want help.
Yeah.
And so I'm also a sex therapist. And so the good thing is it's fun to be able to help them as a GYN physiologically. And then to say, so what do you want, or what's scaring you, or what might be awkward, or what are you getting asked that you're not comfortable with, or how do we get you comfortable with that? How do we talk about self-pleasure and how does that factor in? So it does open a good can of worms. It's an opportunity.
I love it. How many gynecologists are also sex therapists?
I don't know any others, actually. I'm sure there are, but I
think there's one urologist who's also a sex therapist. I'm blanking in my head right now.
I felt ignorant. I felt like I couldn't help them beyond the tissue. And then I would send them to pelvic floor physical therapists to help the pelvic floor muscles. But then they would say, this guy's into this, or I have a lot of trans patients as well. And I just started feeling like I just didn't get trained well enough to really be of any help to people unless I could be a good listener and have something intelligent to say. So I did it for my own comfort, in a way.
Yeah. I mean, I think that a hugely common one, want your opinion on what you think is the most common, but just empowering your patient to talk to their partner about their sex life. There's
Yeah.
so many assumptions that people make about what they think their partner's thinking about them and their sex life because they have no frickin' idea because they don't know how to talk about sex.
Yeah.
I'd say that's the most common
And think
that
of
I
how
see.
crazy it is that you'd share a bed with someone for 42 years. You go through kids, college, home ownership, death of relatives, like 100,000 things in your marriage. And yet you slide into bed, you have some sex, you go to sleep, and so few couples really talk about it.
I mean, it's crazy, right?
Yeah, but if
Like,
we
it's
can
actually
empower
crazy.
that, if we can empower that too, then we could maybe empower a closing of the bedroom gap right in the couple where you don't, do you know what I mean? And then that woman will come to us saying, you know what, I'm not comfortable, I'm uncomfortable, and we decided as a couple that my pleasure counts too. So help me, Dr. Casperson, give me something for that.
Yeah. I think, I've seen urologists turn on this pretty quickly because I think even just a couple of years ago, the urologists are like, I'm just taking care of the patient in my office. Man wants an erection. I'm going to give him an erection. And really this conversation of like, listen, you are doing a massive disservice to this relationship. There's actually a paper talking about the destabilization of relationships when you bring Viagra home in a brown paper baggie.
Oh, I'd love you to send me that. Could you send me
Oh,
that?
it's like, yeah, it's in my pile of something somewhere,
I
but
know,
we can Google it. But really in empowering the physician to be like, what's your plans with this?
Yeah.
Right. And so, I've started doing it, but I've seen a lot more urologists do it.
Yeah.
I would love to tell you that some of the guys are like, well, I talked with my wife, so I'm here today to get some Viagra. 9 out of 10 have not talked to their partner about it.
Yeah, I know.
So I'm like,
you know,
I don't know. So I'm like, okay, so you're in my office to get a harder penis.
Yeah.
You haven't had sex in 8 years, and you haven't thought about what the plan is when you bring the Viagra home?
Right. You're going to come home with this rock hard erection and be like,
In a perfect world?
I'm ready to go. Now,
Yeah.
where does that leave her? And that's the kind of story, I've been in practice 29 and a half years. That's the kind of story that you hear that story 100 times and you start thinking, this needs to be a thing. People need to know about this bedroom gap so that they're not just suffering silently as a woman or being clueless as a man, because neither one wants that. The men don't want that. They want better sex. They want communication. I do think they do. But think about it. Do we ever get taught to communicate about sex? Do we ever get trained? Do we ever get taught even as teens to talk about sexual pleasure?
awful.
Our sex ed is putting a condom on a banana. What was that movie where he goes, just don't ever have sex or you'll die of chlamydia?
Mean Girls.
Mean Girls, of course, right? It's classic.
Yeah.
And it's like not so far from the truth, really. And
Yeah.
we know that telling teens not to have sex doesn't work. And I don't think you're ever too young as a man or a woman to think about your own pleasure or someone else's pleasure. In the Netherlands, sex ed talks about both parties' sexual pleasure. When teens in the Netherlands have sex ed, sexual pleasure itself is a topic, and male and female. And I learned this from 2 Dutch guys on a subway in Tokyo. Somehow, it was more than a 5-minute subway ride, so we started talking about the bedroom gap. And they were like, that's really cool, but in the Netherlands, we learn this as teens. You know how the Dutch are totally straight, right? They don't, like, everything they deliver is straight up. And they're like, oh, we are taught this as teens. It's part of our national curriculum. And I was like, oh my gosh,
Game changer.
I was born in the wrong country. That is cool, right?
That's super cool. The Europe still has challenges getting hormones, though. I wouldn't say they're ahead of us in the whole menopause taking care of vulvas and stuff.
Sex stuff. I think.
Oh yeah, for sex
I think
is good.
sexually they're more open, to be honest. Whereas we're a little more prudish, but then I don't know. I just I'd love to see Americans embrace talking to their clinicians more easily. And I'd love the training to get a reset. For sure in OBGYN, but even primary care. I mean, who says as a primary care you can't bring it up? And you can say, look, we're out of time, but this is important. Your sexual health is part of your mental health, your physical health. We know it. If you stay sexually active, you will reduce depression, anxiety, cardiovascular disease, all kinds of crazy stuff.
There's data in men that sexually active men live longer. We don't have that data in women. And you can say it's a healthy user bias, right? If you're healthy enough to have sex, you're living longer than the people who aren't healthy enough to have sex. But it's
Possible,
like,
yeah.
well, we've got some longevity data.
Yeah.
It's not horrible.
Well, I think said no man ever, oh, I only want to have sex if it keeps me alive longer. I'm pretty sure. I'm pretty sure that one isn't actually what's pushing them to do it. I'm pretty sure it's about something that feels good.
That's
But I'd
funny.
like that for women too. I'd like women to know their bodies better, and that includes self-pleasure. And one thing I tell women when we first talk about self-pleasure, I keep vibrators in every exam room in big glass cases, and we take them out and touch them and talk about them. And some women are so like terrified and skeeved out, grossed out. But the trend in sex toys is not things that look like a penis. More and more are designed by women. And so more and more are just vibration or heat or something that you can use anywhere on your body, Kelly. And so
Hmm.
I call it G-rated masturbation. And I say, just bring this in the shower and put it on your arms. Feels really good. Or on the side of your breast or wherever it might feel good to you. And we sort of baby step in to just things that feel good. Because I think a lot of women feel that masturbation has to be this big multi-orgasmic screaming thing with penetration. And as you know, most of them don't even know that most orgasms in women don't necessarily happen from penetration. So there's a
Yeah,
lot of re-educating, right?
totally. Well, I think, another, just pile on another societal pressure is like, are you doing it perfect enough? Are you doing it correct enough? Are you doing it right? Like this
Right.
whole like performance to sex, which is like just literally wrecks sex. Your brain, if you have your frontal lobe on, the
Yeah.
orgasm can't happen.
Yeah. I mean, right is what feels better. Right is what feels good, not better. So
Right.
right is feels good. And if what feels good is just putting a little vibrating egg or tulip or something, they don't look like penises anymore on your
We got
breast.
tulips at South by Southwest. Did you
Exactly.
get
That's
your
why I
tulip?
said
Yeah, you
tulip.
got your
Yeah.
tulips at South by Southwest.
Yeah. They're actually, my
Plus
patients,
one. I was going to plug that brand. Plus one gave us all tulip vibrators at South by
yeah.
Southwest.
Yes, they gave me a bunch. I actually gave them away to the people I was staying with in South by Southwest and to airline people. I had so many. I was like, "Do you guys want one of these? They're great." They were like, "Oh my gosh, that patient on the plane just gave me a vibrating tulip." But
That's awesome.
yeah, it was
One
easier, you know.
Totally. One of the things I love that you brought up is gender roles being etched in stone in our sexual dogma. And you said a woman's role in the bedroom is to please and serve and not impede the sexual pleasure a man is entitled to. And I think this is both a written and an unwritten rule. Like how many women said, my mom said, I just have to, once I'm married, I just have to like give it to him. So I think it's written, and then I think it's unwritten, that like a lot of women, they were never told that explicitly, but they're like, well, because I'm married, I just need to like, suffer, take it, blah, blah, blah. And it's like, it's this gray world of like, it's not consensual, but it's not consensual. And it's just, I think it's a river of misery. It leads to a lot of resentment. And a lot of people don't know how to get out of that
They don't think
when they
they
find themselves in it.
Yeah, they don't even think they can. They come in and they say, "I really have to do this for him." And sometimes I never meet him, but sometimes I do. And the men are often it's just that lack of communication. They're not bad people, but
Right.
I think this is the sociocultural ethos we inherit. And I think it's been literally so many generations, and I think there's been a lot written about women as pleasers, givers, nurturers. And this is why, it's been expressed in the bedroom, it's been expressed in the boardroom, why women are more likely to back down. Okay, you take the CEO role, I'll be the vice president. And women are speaking up, speaking out. I mean, they're pushing against the glass ceiling. And I would say it's time to kind of push against the glass mattress, right? And say, I'm happy, I love you, but I need pleasure too. And until I can have comfortable sex, we're just gonna kiss, and we're just gonna. And I've had women say, "Well, he's not gonna like that. He's not. We have sex every Friday night," and I'll say, "It's gonna take me/us about 3 months to rehabilitate this tissue and these muscles, and we're gonna come up with something else for 3 months. You're gonna work on intimacy or cuddling." I give them homework. I give
Yep.
them other homework because I think you're right. There's this pressure that I have to do it for him, you know.
Yeah. Yeah, and I agree with you. The majority of people want their partner to be enthusiastic. Like a lot of guys are like, "Hey, would you want to still have sex with her if you knew she was kind of just, rolling over?" But they're nice people who care about their partners. They'd love their partner to have a good time. They don't know how to communicate either. But I think, especially in heterosexual relationships, women give away their power.
Totally. But brings us back to another menopause issue, which is libido and the loss of libido. And so many women come in for a menopause consult, and the libido is almost what's crushing them more than the hot flashes or whatever, because they can't get out of it. They don't think there's anything they can do. And it's almost like a depression where they're like, it's there every day. They climb in bed and they think, I'd rather turn on Netflix than be intimate with my husband. I just would. It's more interesting to me to rewatch The Handmaid's Tale or whatever. And
yeah, I love this discussion. Yeah, I mean, because number one, there's no freaking data on this. But I've talked to several divorce lawyers now who kind of specialize in gray divorces, right? Kids are out of the house, maybe you're retired, and they're pulling people out of the stream way downstream, right? The relationship's already ruined. He's already gender stereotyping. He's already found another lover. Yeah. She's devastated. She still could take or leave sex, right? But the relationship is shattered. And so the divorce lawyers come to me and they're like, we're pulling the people out way down at the bottom of the river. And the divorce lawyers say, hormones save marriages.
Amazing.
They'd see it.
Divorce lawyers say that. I mean, I never thought I'd hear that.
Yeah, and we can't give you data on it, but it's such a, for lack of a better word, juicy topic, because how do you take that and you say, okay, you guys started as this was a sexual relationship, at least one of you still wants it to be. Yeah. What are you gonna do about that? And again, I think it comes down to communication, and I never want it to be, we're blaming the woman for not taking hormones to not have a libido, right? Like this is a sensitive.
He already feels the blame. How can you not feel the blame when it's not mutual? When he wants it and you don't, you're gonna feel the blame. Like if I make a cake and you love it and I don't eat it, I feel guilty at the birthday party. I just do. So I think that's one of the biggest challenges, and we don't have great options for it. We have okay options. And this is why I put time into the sex therapy training that I have, because I felt like, okay, I have Addie, FDA approved for female sexual dysfunction, and I have Vyleesi, an injection, which is sort of on-demand dopamine release. Woohoo! For 15 hours you want to have sex. But I think much more important than an on-demand Band-Aid is to build the libido from the ground up again. And I find that takes a combo, usually, of like some testosterone and then what we call bibliotherapy, which is just a term for bringing erotic content into the brain through apps like Quinn or other audio porn. There's a whole industry now called audio porn, which is a terrible term because everyone goes, oh, porn, I don't like porn, and that's bad for women. This is not that. This is largely made for women, produced by women, and stories. You can put headphones on and climb in bed at night and listen to some of these stories. And yeah, some are silly and corny, but we know that the female brain, especially when primed with a little testosterone, stores that erotic imagery. Yep. And it's like a savings account, and we lie on our partner's shoulder, and it feels more masculine to us. It feels more physical and sexual and male to us. And again, I don't want to imply that gay couples don't have this. They have these issues, and we really, it's wrong of us to think they don't have issues. But for the majority of couples who are heterosexual, I think that, I think the therapy works for gay couples just as well, testosterone and bibliotherapy. But bibliotherapy could be renting movies with erotic content, and it doesn't have to be like crazy porn, women screaming. It can be something romantic that has a sort of sexual tension. Many women find that super erotic, and they will store.
What was that big British show that everybody was talking about how sexual it was?
Bridgerton.
I know. I never saw it. I hear it was very stimulating.
Very, very steamy. Very steamy.
Like, makes you warm.
I had
Makes you
patients that were
warm.
having like Bridgerton, not parties, but like they and all their girlfriends were watching it, and
Yeah.
kind of forcing themselves to watch it, but not forcing. But anyway, long-winded way of saying the lack of libido is part of the bedroom gap. It is. The bedroom gap is certainly physiologic. It's certainly worsened by all the erectile dysfunction meds, but the lack of libido is a psychological part of the bedroom gap of a woman climbing into bed and wanting literally to do anything else but have sex, or as many women tell me, never have sex again. They say, I'd be fine. I'm not a weird person, but I'd be fine if I never had it again. What about your husband? Oh, he would like it 4 times a week. So we compromise. We do it once a month and I just get through it.
Right.
That's the gap. That's the bedroom gap.
That's
really.
the gap.
Yeah.
Yeah, well, it's wonderfully complicated. It is biopsychosocial. Don't forget the importance of estrogen on libido. We gendered these hormones. We said testosterone is the libido hormone. That's not true for everybody.
I just wanted to bring it into the talk.
Yeah. No, to me, I'm like, hormones are key. And if you weren't having great sex to begin with, now you have low hormones on top of it.
Get it.
Right? Forget it. But you'll see these women, they're like, I had an amazing sex life. We're great together. I love my husband, blah, blah, blah. And then it just got gray, right? Like it just was it was a gourmet meal I loved showing up to, and now it's mushy broccoli, right? Then you're like, okay, that might be more of a hormonal than like, I never liked it, right?
But Kelly, I'm a hormone fan just like you, but I want to repeat that sometimes hormones are not enough. That sometimes you, me, or a sex therapist, and we can talk about how they can get to a good sex therapist even online, need to peel back some layers of the onion. Is there a sick child at home, a sick elderly parent at home? Are they losing their business? Are there financial stresses? All these things impact too. So
resentment.
Libido,
Resentment's a big one.
Well, that's true. That's true. But there are so many factors and if you do not take the time as a clinician, you may miss the fact that, there was an affair 2 years ago. So they just don't feel, she doesn't feel comfortable yet. Or How does she feel about how she looks? When we look at studies of couples with a massively overweight female partner, 300 to 400 pounds, okay? Not talking about 160. I'm talking massive. Almost 100% of their partners find them sexually attractive, gorgeous, and they don't even know what you're talking about when you bring up the weight. But women don't necessarily feel that. We all have weight that we're comfortable, and whether it's our stretch mark or our mole or our lumpectomy scar, there's something that may make us feel self-conscious and not feel like society says we have to look like, Julia Roberts getting into bed. So there's a lot of pressure on women to stay young looking, stay thin, get implants, get your butt lift, whatever it is. I mean, I had a woman come in today asking for injections of fillers into the labia. She said, I'm just too self-conscious to have sex because my labia have sagged and I need them puffy. So she said, will you inject fillers in and then I'll feel better? And I said, no, I won't. I can't say someone else won't. I certainly could send you to a plastic surgeon. And if that's what you need, do that. But I said, but you have really severe loss of estrogen deficiency in the vagina. So let me work on that. And, you talk to the plastic surgeon, because shame on me to say, no, you can't have that. I mean, if that's what she needs, that's what she needs. If you need Botox, you want Botox, it's not for me to judge and say, Kelly, your skin looks great. I don't think you need Botox, right? I mean, you do have beautiful skin, but it's what we're allowed to make our own decisions about what we need aesthetically. But I just think the lack of libido can be quite a multifactorial thing. And if you are suffering from lack of libido, I hope you'll find a clinician who will take the time to sort of look at all the angles. And if your physician doesn't, if they give you vaginal estrogen, good, you got better than most. But if they don't have the time or expertise to talk about the other issues that might be impacting this, you can find a sex therapist. You can go to asect.com or .org. That's the American Academy of Sex Educators and Certified Therapists. And you can put your zip code in, And an asect trained therapist can, I'm sure now since COVID, many more of them do online stuff. And I have great names of great ones around the country. So anyone can find me on mariasophoclesmd.com or princetongyn.com just to say, hey, I live in Iowa and I need someone. So I want people to feel that's not a shameful or crazy thing. Sometimes you go once and you get some key unlocked and that's all you need.
Yeah. My whole TED talk was like, a little bit of education goes a hell of a long way.
Yeah.
Like, oh, most women don't have an orgasm just by putting something in their vagina. Oh, okay. So I'm not normal that I need my clitoris stimulated. Thank you very much.
Yeah.
Right? Like, it's like a little bit of education goes such a long way. Like, people are like, this is how it's going to be forever. And like, they see a sex therapist once and they're like, oh, turns out I'm normal. I just needed to know that.
Yeah. I had a very, very progressive mother-in-law. She just passed away, but my husband and I got married 29 years ago, and she literally took him aside before the wedding and was like, I don't know what your father ever told you, but your father, he's kind of conservative. He might not have really told you what you need to know, so I'm just going to do it, And she just launched into how women have orgasms, what makes them happy, what you need to do, how she has to come first, like all this stuff. And my poor husband was like, oh my God, my mother just told me all this. But good for her, right?
That's a big deal. That's very, very cool.
Isn't that huge? Yeah.
I mean, it comes from love.
Oh, yeah.
Right?
And I thought, she cares about...
She wants her son to have a successful
sex
pair
life.
Bonding.
Yeah.
Totally.
Yeah. I mean, oh my gosh, could we make that standard like parent talk someday?
So sweet. Dude, I mean, you talk to these people when they're like, the people who are like, yeah, my mom, usually mom, but dads do it too. Like, my mom told me everything. Nobody's like, I wish she didn't do that. Right? Like, everybody's so grateful about the parent who like gave them the heads up.
Yeah. But
so
actually,
sweet.
Many parents don't. They really can't. They just can't talk about it because their parents didn't talk to them.
Yeah.
So they have no,
I'm like the annoying urologist at the kids' preschool, right? So we had this preschool. This is pre-COVID, where like the parents could actually get together, and it was like the parents would have a meeting every month. It was a co-op preschool. It was very cool. And they were, they're like, what do you guys want to learn? Blah, blah. And I'm like, there's this amazing sex educator in my town whose specialty is educating kids, right? She does kids, she does adolescents, she does blah, blah. And I'm like, I would like the sex educator to come in to talk to the parents about how to talk to preschoolers about their bodies, right? So like I offered it up and she came. And afterwards, the feedback was like, favorite talk of the whole year. Wished they had it when they were growing up. And it was the most the most where the parents were like, I don't know about this one. Right? Like, it was like, the delta change of like, they went in being like, not sure. And then being like, best thing ever.
Yeah. Yeah.
It's like how to talk to your preschoolers just about their bodies.
Yeah. I mean, I wish I had that, I mean, my
cool.
poor kids got baptism by fire because
they've got a gynecologist for a mom.
Well, not just that. This is like going to get me in trouble. I had a new electronic health record with this beautiful system where I could actually take pictures of the vulvar disease, so that over the course of the appointments, as it got improved, we could track it. So I started using it, and I didn't realize I had hooked it up improperly. So instead of only staying in the health record, it was also feeding to my living room TV screen. Like, how this happened. Anyway, thank gosh I fixed it right away, because the first day I come home, I'm really excited about how progressive I'm being. And my 3 teenage sons go, Mom, you've ruined sex for us forever. We don't ever want to see that again. I was like, what are you talking about? Oh my God. I called the IT guy. I'm like, gotta get it off this TV screen in my house. Luckily,
That's wild.
No names, but so my efforts were not always correct, but I tried.
That's awesome.
Do you have little vulvas in your office? Those little vulva puppets ever? Mm-hmm. Have you had those? Yeah.
Yep. Yeah. And mirrors.
The mirrors.
Right? Mirrors.
Yeah.
One thing you got a huge clap about on your talk was when you said a right to pleasurable sex.
Yeah.
Why do you think this struck such a nerve with the audience?
Because I think so many women don't think it's their right, or they do deep down, but they're not going to go out with posters and march in Washington saying we have a right to pleasurable sex. We've just lost our right to abortion. They feel like people are dying of cancer. There's a war in Ukraine. And but deep down, they just dream of actually having that right. And at least with Harvey Weinstein and Me Too, we blew the lid off of some of the horrors, right? So we've taken one step towards not being assaulted to get a job. Woohoo! So that's how darn far we are from this, right? We've just had a movement, Me Too, that has said, it's not right. It's not right for a scummy, horny media exec to rape you for you to get your job. That's how low the bar is, Kelly. Okay. And we're all happy about that we've maybe made dents in that. By the way, that's all still happening. It's just hopefully happening a little less because people are thinking, oh, she could blow the whistle. But sexual assault on campus is rampant. So there's still so much male entitlement to sex and to sexual pleasure and to women's bodies for their sexual pleasure. So I don't mean to get all despondent and depressing, but we are so darn far from true gender equity in the bedroom that I think when I said that's in my book, I have a little appendix, just Women's Sexual Bill of Rights. And, the number one thing is right to comfortable sex, and the number two is right to pleasurable sex. These should be basic things. No man ever said, boy, I wish I had the right to comfortable or pleasurable sex. Men have had that for millennia. So that's why it struck a chord, because it was one of those so obvious, but nobody says it, right? That's what I think. Why do you think it struck a chord? Did you? Sorry, I didn't mean to.
No. I think excellent answer. I think you're absolutely right. To me, you spend, and I didn't show up fully developed having a podcast and knowing a crap ton about hormones and sex, right? I was there too. And it's you get to a point though where you forget the bar is so freaking low still.
Yeah.
Right. And it's you're doing a great job. I'm doing a great job. There's great people doing great jobs. But you're dude, we forget this is 50% of the population. This is not an autosomal recessive disorder. Yeah. Right? This is so huge.
Frigid woman, which, not that I like the term, but that's a term, it's not like once in a blue moon, women are standing up saying, I'd like to have pleasurable sex. It's I think we all would. And I think we'd all like to have comfortable sex. And I don't think that's a lot to ask.
Yeah. And it's interesting. One thing I love about how you talk about this is your willingness to be dude, there's gender inequality in heterosexual relationships. And I think one way to level that playing field is you have to frickin' talk about your sex life.
Yeah.
You have to be uncomfortable with possibly making another person a little uncomfortable.
Yeah, your girlfriend or your clinician or your partner or all of them. And I think that until we break, I think I use some term free ourselves, emancipate ourselves. I picture women literally smashing chains off them and saying, I'm calling Kelly and I'm going to talk to her because I'm not happy. Or I'm calling, my cousin because honestly, she's kind of open-minded and I think she won't think I'm crazy for talking about this. And how sad that women have to say, gosh, I hope someone doesn't think I'm crazy. No man ever is judged when he sits at a football game or a bar or his kitchen table with his guy friend and they talk about sex. No man ever looks at his friend talking about sex and goes, dude, you're nuts. You're talking about sex? It's just a given. You masturbate? Duh. I've been masturbating since I was 12 in my bedroom. Yeah, any guy has. And nobody has any shame about that. Right? Mm-hmm. So can we lose the shame? And I think you're right. It starts with conversation and with, maybe you and I need to go host little groups where we just have open table, open mic night,
It really is how I think the world gets changed, truthfully. Is small groups of women talking about things. The other thing I love, just to wrap up, the other thing I love about your TED Talk is that you called out in the open what people's fear is about estrogen. Because if you had done that talk and just said everybody needs vaginal estrogen and hadn't addressed that people have a bias, incorrectly a bias about estrogen causing cancer, that you would have given them information, but they wouldn't have done anything with it. And the fact that you like brilliantly called out that fear in your talk was, it was brilliant. Very, very well done.
Well,
Anything else you'd like to say about that?
It's the elephant in the room. And I have to say, I'm a little tough sometimes with my patients where they go, oh, I'm kind of squeamish. Like, I grew up in the 90s and the fears. And so lots of them. And I think I'll just skip it. And I just put my knees right up to their knees. I sit down right across from them and I lean in and I just say, I want you to name the fear. I want you to tell me, what is the fear? Just say the name, no judgment. I want to hear. Is it kidney disease? Is it acne? Am I getting warmer? And I know what it is, And they go, well, no, it's well, I mean, breast cancer, everybody's going to get it. And I think they might get it from hormones. And I go, okay, let's talk about that. Let's just talk about whether that's actually the case. And I say, thank you for telling me honestly what your fear is, but I have to bring it out of them. And once we name it in the room, there's the enemy. It's right in the room. And they might still be scared of it, but at least they've heard from my mouth that vaginal estrogen does not pose a cancer risk. And they can take that info and decide what they do.
Totally. Yeah, I agree with you 100%. Is you got to name the fear. And then another step is like, where did that come from? Who told you that?
Yeah, my
and the fear of breast cancer and estrogen, people don't know. They will never say the WHI in 2002 when the media took it. They don't know that. It's just in the ether.
Yeah. It's often someone in their family who got cancer and told them, I think the cancer's from the hormone. I don't know what you feel, but I hear that a lot. Well, my grandmother had cancer, so she said never take hormones because it probably caused hers. Oh, really? What was her cancer? Colon cancer? Okay.
Right. Yeah. Our brains love to correlate things. Like our brains really, really want to blame something. And I'm like, a lot of times with cancer, we don't have anything to blame.
Yeah, and I don't want to crap on anyone's grandmother or hairdresser, and I'm clear about that I'm really sorry that she had that cancer. But your decision to do this now today is not impacted by that cancer in the 1970s. And I think if we can help them divorce that, it helps. So,
totally.
We covered a lot of different stuff from the talk. I'm really grateful.
It was a very good talk, my friend.
Well, yours was great too. So we have 2 good talks people have to listen to.
Doctors doing TED Talks.
Bring it on.
I mean, it's really an important, where do people get their education from, right? Yeah. The TED platform and what they stand for, ideas we're spreading. I am a disciple and convert of, I love that organization for being but you got to keep it short and you got to keep it interesting because that's, we watch it on the internet. You got to keep it short and interesting.
They changed their thing from ideas we're spreading. This week they launched a new thing is ideas change everything. And so I think
I love that.
You and I, because we want our ideas to change behavior so that women can avail themselves of what we've spoken about and so that they can feel empowered to change their quality of life, even their longevity.
I love it. All right. I'll put it all in the show notes and the link to the TED Talk. Go watch it. And thank you so much.
3 years to talk again, huh?
I know. Hey, God bless. Hopefully the podcast will still be going on.
Oh, I hope so. But, the TED Talk has almost 1 million views already, and it just came out a couple weeks ago. So I think that's a good sign that women want to hear this, and I hope men want to hear it. And, you and I will continue to spread the word, spread the message, and I'm really grateful. Thanks for having me on. Appreciate it.
Absolutely. Thanks for coming.
All right.